Hello everyone, my name is Ram Nataraja. I'm a consultant academic paediatric surgeon at Monash Children's Hospital and also have different roles in global surgery, global health and also simulation-based medical education. It's a great privilege to be speaking to you today as part of this program, Simulation Here, There and Everywhere, but also the wider RACS ASC. We've got an action-packed virtual congress this year and I hope that you're enjoying it. I'll now share my slides. So this is the presentation today, and I'll be talking about the application and assessment of a novel simulation-based education program in Myanmar with clinical impact. Before I go on, I'd like to acknowledge the traditional owners of the land of which we're all gathered here in our various places, and also acknowledge their elders past, present, and emerging as well. At this point, I'd also like to acknowledge my Monash Children's Hospital International Myanmar faculty. Yinma, who is on the left with me, has been a driving force of this program over the last 5 years, as has our emerging faculty here. They're young pediatric surgeons who were initially our participants, and then were identified as future educational leaders. We've trained them up, and they're now delivering our content in country, or they were until the recent unfortunate events. Certainly, our prayers are with them all, and we're hoping for a resolution and a peaceful resolution of the trouble there relatively soon. So I'm certainly dedicating this presentation to them because they were, some of them were meant to be with me today to present this as well. So this is the overall what we'll be talking about, and I thought I'd start with just saying what is surgical simulation. So this is the acquisition of essential core technical and cognitive skills in a safe, controlled learning environment prior to patient contact, hence ensuring patient safety and clinician preparedness. And this is certainly what the cornerstones of what I would define of what we do. What is it to me? So this is a double glove model which I first designed back in 2002 with my colleagues at Great Ormond Street. We did validate it, but in those days we had to go to the theatre setting, beg, borrow and steal real clinical equipment to do it out of hours, and that was how we first validated our first simulator. Now we have this, which is an example. It's the ESM, which is a very portable, validated laparoscopic trainer, affordable now and can be put into any setting. And it forms a cornerstone of some of our laparoscopic training programs, both nationally and internationally. As I'm sure you all know, and I'm talking to an educational audience here, there's very different forms of simulation-based medical education. And as you can see here, using either scenario basis, probably people are aware, part-task trainers, laparoscopic simulators, immersive sim, communication skills, hybrid sim, and also the new novel technologies such as virtual reality or mixed reality as well. So the overview of our existing program, we've been operating in the country since 2016 in partnership with not only the Australasian College of Surgeons, Australian Aid, but also the University of Medicine 1. The photo on the left is us signing the Memorandum of Understanding, which I think is a key core component of having a successful program, is engagement with the clinicians and also the educators in that particular setting. As you can see, we've done a varied course, including clinically based courses as per the learning objectives, which were specified by my colleagues on the ground, but also in terms of educational, so research design, surgical educational courses, faculty development, and we were planning to do other courses moving forward. The Intussusception course was one of our first courses, and that's actually a key part, and I'll be presenting some of the clinical outcome, because we actually do have 3 years worth of data to actually assess its clinical impact. The courses, as I said, the last 3 were actually being delivered by my colleagues under our guidance, and so we were transitioning to this program being repeated for the new pediatric surgical trainees as they rotated through their training in Myanmar. And certainly the course that was meant to be performed last month, which had to be put on hold, was meant to be a virtual course and was a repeat of one of our previous courses with our Myanmar faculty leading, and also the NetSim course as well. But we will hopefully resume that once things have settled. In terms of examples of surgical simulation we've done there in terms of here, there and everywhere, you can see here we've turned a room, which is the standard teaching area at Yangon Children's Hospital, into an area where we can do scenario-based design. And you can see Yinma in a bottom photograph is actually then leading it, using iPads, using props, and also donated equipment that we donated to the facilities themselves. But also using animal models. So this is for the surgical airways, the cricothyroidectomy, and also chest drain insertion as well as things like intraosseous needle insertions, which we'll look at the model in the next slide, but also stoma care, nursing care, really interdisciplinary team scenarios. And this is obviously from all of the courses over the different learning objectives. And then also in terms of how to care for and resuscitate babies through scenarios, through equipment, through actually adapting things to their setting as well to maximize the clinical effect of the equipment that they actually have. And in terms of technical skills, also things like PEG, so PEG tubes, talking about nutrition, talking about calculation of enteric needs with our gastroenterology colleagues Ed there. Also procedures like putting in UVAC, or UAC, UVC, sorry, or putting in a urinary catheter as well. And things like big bowel anastomosis, and also basic surgical training. You can see Yinma here is demonstrating some, not tying, but you can also see that the simulator we're using is a very low cost, locally made one, but is very good for doing that. And you can see this is our interosseous insertion, which we can't claim credit for, but is a crunchy bar wrapped up in elastoplast, and it gives a very good fidelity for insertion of an interosseous needle. But also laparoscopic training, and you can see these are the ESMs in action. Very much a successful program there. There has been some concerns about teaching laparoscopy in this setting, but it's definitely applicable to this setting. And certainly we can actually offset some of the difficult learning curves that we had in high-income countries into this setting here. And you can see everyone's having fun, but you can also see the fact that actually you can turn any space into a laparoscopic training facility without the need for electricity per se. And we do loads of validated tasks, which are all validated for acquiring surgical skills, but they're all low cost, you can see, and you can see the evolution of the double glove model in the top right-hand corner from our initial exercise. And they love that, it's low cost. They really get their skills up, we can assess them. And as you see later, we can also harness technology to make that better as well. But what do we do? As we probably all know, there's various things in laparoscopic surgery that are different. The 2D to 3D realization, altered hand-eye coordination, the increased fine motor skills with longer instruments which amplify those movements, the fulcrum effect, paradoxical instrument and hand movements, loss of haptic feedback, and also altered depth perception. All of these skills can be picked up on low-cost models in any setting and can help with the adaptation and adoption of new techniques in different settings and to decrease the complications prior to patient contact. And in terms of the cognitive skills, we designed with my colleague here, Margaret Bierman, and also Natalie Webb, the Monash Surgical Trainers course, the MST course. And we did this with a partnership with UN1 to educational leaders throughout the whole of the university for surgery. And this was a highly successful course teaching educators the various skills that they need, akin to ones that we do normally in a high-income country. But we also taught communication, we taught team working skills, you can see the helium stick here, but also role-playing, giving feedback, how to discuss with a colleague, breaking bad news, how to give negative feedback or more constructive feedback as well. And this happened in both settings, and you can see here, these are case-based discussions, really interactive sessions, and teaching that higher level surgical cognitive skills that you really need to improve patient outcomes. And you can see they really get into it and quite animated, which was great to see as well. And in terms of evaluation, everything we do is built into evaluation. And one of the things when we started the program was we would advise, don't get evaluation, they'll just give you positive marks, it doesn't matter. But you can see here, this is an overview of some of the evaluation for our courses broken up into theory and also the simulation components. And you can see actually that the simulation is actually sometimes ranked higher than the theoretical side of the workshops, but more importantly, although they're ranked highly between 8 and 9.5 in terms of the median scores, you can see though that the range is huge. So this is honest feedback. Some people were ranking it 2 for the simulation part, they did not like it. The same for 3 for neonatal simulation, but generally people did, and this means it's honest feedback that we're getting, so very worthwhile to do evaluation. And this is the same for our surgical, so the MST, the Monash Surgical Trainers course, and also the research courses. There's a good range between 5 and 10, which although overall is very good, it gives you honest feedback, and certainly the qualitative comments we got from this were highly useful in tailoring these courses to this setting as well. And we also use pre and post course Likert scale evaluation as well. And you can see here, this is for air enema, which we're going to be talking about a bit more later. But when we did the course and we did in situ simulation for air enema reduction of intussusceptions, you can see there was a significant increase to either performing or assisting an air enema in this setting after our intervention. Great, you can say that's great. So people are more happier after doing simulation or feel more happy to do it, because obviously it's a self-assessed Likert scale. But how do you know this is honest feedback? Well, we also asked them about barium enema, and there was no significant difference between barium enema, and this meant that actually they were giving us honest feedback, because we wouldn't expect our intervention to have affected barium enema competency, but we would air enema. So you can see here, this is honest feedback again, highly important to evaluate everything we do, regardless of the resource setting that you're in. And here you can see delivering teaching for the MST course, there was no significant difference. And that's because we had educational leaders on the course. But in terms of planning, there was. In terms of providing feedback using a WBA, there was as well. Highly important that actually this is honest feedback that we can get from the participants. Are very worthwhile to do evaluation in a low middle income country and really get the evaluation really integrated into the start of the program itself. In terms of qualitative, we got some positive feedback. So you can see here, the themes that came through in terms of actually practicing with simulation is very important. There were things that weren't, so saying dysmotility, intestinal dysmotility, not useful for us. We just don't deal with it. Babies don't survive. We don't need this, so we adapt to content. And you can see here in terms of introducing new concepts in terms, and this is feedback from our research course, so that yes, you know, this is better. We're now understanding more about evidence-based medicine, how to evaluate research. And then other things, which obviously for me, in terms of doing live demonstrations, in situ simulation, really powerful feedback to back up what we're doing. So in terms of Myanmar, where were the next steps? So you can obviously see the distance here, and the next step was actually a remote laparoscopic skills program. Now this sounds completely out there, but bear with me. So we're going to do that between ourselves, obviously at Monash Children's Simulation, and UM1, as the University of Medicine 1 in Myanmar. And having gone and shown you the photos from the back of a room in the middle of the hospital, there's now a purpose-built simulation center with very good Wi-Fi. So we've gone to the next level where we can then do that. And this is a kind of feedback you can now get with technology and low-cost technology. You can see here, this is from one of my courses. You can see I get metrics from the individual movement of the instruments, that distance, the handedness, the off-screen, the distance between the speed, the acceleration, the smoothness, all very valuable, which I then use by watching the videos. I then give them gradings and I give them written feedback, and then they resubmit evaluations to me. Can be used remotely, can be used in Myanmar or any other setting in a lower middle income country with an expert remotely then giving feedback. And we've done this here. So you can see we've actually trialed this with COVID. So COVID has changed the paradigm for many things, especially educational delivery. And you can see here we've run some successful courses for laparoscopic skills. And this is throughout all of the states of Australia so far. So in terms of just an example of the clinical impact, so I said we're going to talk about intussusception, and certainly this is a very, very common cause of small bowel obstruction in infants, where the bowel telescopes in on itself, it causes compromise and can be life-threatening. In low middle income countries, the majority of babies get an operation. In high income countries, the majority will get an air enema or non-operative intervention, so over 90% in fact. In terms of the region, so what do we know about Myanmar? Not much, no real information about intussusceptions there. We do know it's a big population, limited pediatric surgical centers and also surgeons to deliver it. We know that in Vietnam, the incidence is much higher than Melbourne. And this is a very good paper by Bynes et al., which actually compared the incidence, and you can see there was a significant difference between the two of them. And also Thailand, you can see it's actually maybe potentially lower than Melbourne, but the data tends to be slightly less reliable from that setting, and there's actually not many papers for that. But the ones that are doing air enema, you can see they range from Vietnam, that's well established, to more than 95%, down to a success rate of 68 in Thailand. I designed and validated a new simulator. This is Indy. We did a validation study at MCH before going across. It's a baby doll, which I drilled holes in, traumatized my then 3-year-old daughter drilling holes in babies, and made tubing out of stuff from Bunnings and validated it, more importantly, before we applied it in Myanmar. And it cost $17 to make overall, very low cost. We used in situ simulation at Yangon's Children's Hospital and got them in the normal clinical teams, made them through it, designed scenarios showing videos, donated the machine as well, the Intussusception machine, so they could use it, made sure that all the equipment we were using was actually good for the local practice. And we made sure that they could actually then get the image of when they were using the image intensifier was x-raying the right portion. And also you could get the intussuscepted bowel, although it was pushed back a bit too much, but then combined with videos for good introduction, reductions of air enema and also not so good introductions as well. And then the project timeline was longitudinal, so it's prospective data collection for 3 years compared to a 1 year pre-retrospective look for pre-implementation of the Intussusception project. And the initial one, which you just saw, was the in situ prospective data collection. And then I did a mixed method study for this as well, which I actually included as part of my master's thesis. And these are the overall results. So about 80 patients per year, operative rates decreased from 80% to 50%, intestinal resection rates increased and doubled from 15 to 31, which is good. It implies that it's back to international standards. And you can see here that was a significant difference there. But then it stabilized in the subsequent years in terms of all those 3 outcomes. But the success rate and recurrence rate was actually low. So the success rate was 91%, so excellent, on line with high-income countries. Importantly, the length of stay was significantly lower, big implications for this setting, less need for drips, antibiotics, operative complications, inpatient stay, all of those things as well. Very good for a low resource setting. And the length of stay here, 4 days compared to 7 days. So the qualitative research, I did a thematic analysis, and we looked at it actually as looking at my personal reflexivity as well, but then looked at 4 specific questions for them. What are the advantages of using it in this setting? What are the challenges? What factors facilitate it? And any other comments that they had. We had a focus group electronically via Zoom, and I provided the results beforehand. And this identifies some major and minor themes, and major ones being expanding conceptions of healthcare professional education, realizing far-reaching advantages, promoting critical analysis and reflective practice of clinicians, and adaptation to clinical practice to local contexts, as well as some minor themes as well. And in terms of just some examples here, so you can see that for this domain, simulation-based teaching was, well, before we implemented the clinical, first time we've done this, very useful, very good point for us. Juniors are the main person to do the air enema reduction. They get much more experience after the simulation courses, and then they're familiar to the air enema reduction right directly to the patient. Previously, we had to train them on hands-on experience with the patient, which is not appropriate for them. And simulation in the real place with the real machine and the real people practicing around it can make it make the young, more junior people think it's a real situation. Powerful stuff. And in realizing the far-reaching advantages, they're busy. Many emergency operations reduce the workload of us and the theatre staff. Parent satisfaction is very good. Most of the parents are afraid to operate on their child, and low risk for post-operative events reduce shorten the hospital stay as well. Great far-reaching, really high-level cognitive themes that came out. So in conclusion, the achievement of international gold standards for the air enema success and intestinal resection rates was great. So it was also sustained over 3 years. The integration of self-delivered simulation-based medical ed training was key with our faculty, as we said, and there were far-reaching clinical effects for the healthcare system, not just for the individual patients themselves. So there's been a paradigm shift in the approach to training and the incorporation of simulation-based medical education into routine practice in Myanmar, which has been excellent. The mixed method approach of the main project allowed much more deeper exploration of the clinical results and future direction than we could have done just with the quantitative, because some of it didn't make sense. But really probing that in the interview with my Myanmar colleagues really then did get to the root of what the issues were, and also explain things that we didn't understand. And it also has potentially indicated that these results may be the gold standard for Myanmar, and we don't necessarily need to chase every baby undergoing an air enema reduction as we do in a high-income country, that maybe this is the best and the most appropriate for this resource setting. And in terms of Kirkpatrick levels, there's pros and cons for using this. And this is one of the ways to evaluate it, not without its drawbacks, but certainly for this project, we showed level 4, which is improved patient outcomes from a simulation-based educational intervention over a long time, sustained over 3 years. So low-cost simulation in a low-income country can have a significant clinical impact. The technology should be appropriately implemented. Sustainability and handover to local staff should also be at the core of these programs. Evaluation and research should be integrated in all aspects and should be combined with the upskilling and empowerment of local educational leaders and partnership with local educational institutions as well. So thank you very much. Take any questions now. I really want to thank all of my participants and faculty in Myanmar. We've become close friends over the years, especially Yinma, Nue, and Prof AA, who are the educational leaders there. And definitely our thoughts and our prayers are with them during this difficult time. And we hope for a resolution of the political situation there. Thank you.